Good morning, everybody. We're going to keep waiting for everybody to join us before I hand over to our host, Sibu, to introduce Dr. Lesedi.
Okay. Hello, everyone. Okay, so my name is Sibu, and I am going to be your host today. I just would like to um, mention that we've got quite a lovely agenda ahead of us. And so we're just going to go right into it so that we don't waste any more time. Alrighty. So, distinguished guests, colleagues, and friends, it is a pleasure to have you join us for the breast cancer webinar today. We are lucky to have a panel of outstanding people who will discuss this important topic from their points of view. Our panel consists of a seasoned doctor, a strong survivor of breast cancer, a committed activist who stood by his wife through her own journey of breast cancer. And these combined perspectives, expertise, and life stories only promise to make this webinar enlightening and of course motivating. So let's begin this insightful journey together, and here we go. So to start off, it brings me great pleasure to announce our keynote speaker. You can see her beautiful face already. She lightens the room. She is a renowned and she's a renowned person with an abundance of medical expertise and outstanding qualifications. She has 6 years of experience, a successful medical practitioner, and possesses a highly sought degree in doctorship. Steamed from Sefaku, you will correct me on this if I get it wrong. Sefaku Magota Health Science University. Their path through complex networks of medicine as well have led her to esteemed establishments like Rimamosa, Helen Joseph Hospital, and several other primary health clinics. With a focus on family medicine and emergency medicine, she's made a lasting impression in both public and private spheres generally. She has an array of credentials, including the pediatric advanced life support, advanced cardiovascular life support, and a mastery of emergency medicine approaches to trauma. This demonstrates her persistent commitment to developing healthcare. Beyond her skills of the workplace, she's also a paradox of an outgoing introvert. So you can say that she is 100% a foodie, but also very, very much an outgoing person and enthusiast of the outdoors. So our keynote speaker, without no further ado, is Lesedi Tumani. Well, Dr. Lesedi Tumani. Over to you.
Thank you, Sibu. Good morning, everyone. Thank you for that introduction, Sibu. But basically, I would call myself at this point a general practitioner. I practice medicine to help improve people's health, basically. I'm happy to be part of this talk because I believe in health awareness in all aspects that come, with different diseases. But this one in particular is quite important because it's a very prevalent and life-threatening, form of cancer that is found in most women worldwide. And I believe that when we are aware of warning signs and, we know that if we find something to seek help for, you go find help. And when it's treated sooner, the outcomes are better than if it's caught much later, when the stages are far off and treatment can be difficult. All right, so I am a graduate from Medunsa University, now changed to Sefako Makatu Health Sciences University. And here I start the presentation. Can we change, Sibu, the slides onto a table of contents? But basically what we'll be going through would be our introduction of what breast cancer is, and as well as going into the statistics, introducing the different types of breast cancer, the symptoms associated with breast cancer, the risk factors thereof, self-examination and diagnosis, as well as treatment and support. Can we go to the next slide, Sibu? So on introduction, what is breast cancer? Can we move to the slide? The breast cancer basically is a type of cancer that is occurring in the cells, the breast cells, that actually what happens is that those breast cells start to grow and divide uncontrollably, which is not the norm that happens with our body cells, and that usually occurs with any form of cancer. So when the cells actually start to grow uncontrollably. But in this case, those tumor cells are actually able to spread from their primary site, this in this case being the breast. So they're able to spread from the primary site through the blood and the lymphatic system, and then spread to places like the liver, the lungs, the bone, and the brain. So this usually we call it metastases, where the cancer has spread beyond the primary site. Can we move to the next slide, Sibu? So in terms of statistics, amongst South African women, breast cancer is actually the most common the most common cancer affecting South African women, with a lifetime risk of 1 in 27 women being affected. And amongst Black South African females, they have a 3-year survival lifetime risk, overall survival of 59%, and that being because of late diagnosis, late presentation, where you are at stage 4 of that cancer, and it's quite difficult to treat stage 4 of breast cancer, and as well lack of access to good healthcare services. For example, in South Africa, Limpopo women actually who are diagnosed with any form of cancer, for them to receive chemotherapy or radiation, they actually need to be transported almost daily from their home hospitals to Johannesburg to get treatment. And given also the situation that we had earlier during COVID, when there were fires in the Charlotte Maxeke Hospital, that actually halted treatment altogether. And men as well are affected with breast cancer. The incidence thereof is between 1 to 3%, but it does occur. Can we please go to the next slide, please, Sibu? So in terms of symptoms, what do we look for? I like going into, symptoms in terms of what you see first. But most importantly, I need to say this, that sometimes it does occur that a person has breast cancer and they are not having any symptoms. When you palpate your breast, you don't feel anything. There's no skin changes. There's no nipple changes that could actually say that perhaps you may be having breast cancer. But in those cases, commonly when you have symptoms, a lump is the first symptom that most women experience, as well as skin changes. So the skin changes can occur in the form of, changes in the texture of the breast. Now you start seeing the breast being swollen and looking like the skin of an orange, and that we call peau d'orange. In some cases, you get ulceration as well. You can get dimpling or puckering of the skin as well. Also, very close to our breast, we have our armpits or axillaries. So these axillaries usually have lymph nodes. Those lymph nodes are present and get swollen in cases of infections or cancer. So you might have swollen lymph nodes in your armpits. As well, very important, changes to the nipple as well. You can have your nipple being retracted or inverted, and as well having nipple discharge and a bloody nipple discharge, which is quite suggestive of malignancy or cancer. Can we please change the slide? So moving on to the types of breast cancer. How we typify breast cancer is actually checking the origin of cells the breast cancer is coming from. So basically, if you go to the next slide, Boo, this is basically the anatomy of the breast. So you see that we actually have lobules and ducts, and these are common areas where the breast cancer could originate from. And you'll see with the different characterizations or types, actually they're associated with the origin of those particular cells. Moving on to the next slide, Boo. So if we speak of ductal carcinoma in situ, this is a type of cancer that is actually non-invasive, and it's still located in the primary cells that it has come from, basically the ducts. And this occurs in 20% of cases. So this, when it's at this stage, it's actually quite treatable. It hasn't spread, so it's in its early stages. And moving on to the lobular carcinoma in situ, this cancer is one that is originating from the lobules of the breast and is also non-invasive. But interestingly enough, it can present with a non-palpable mass. So you may not feel that you have a mass to start with. So what a doctor or practitioner would do would actually send you for a mammogram. And if the mammogram is inconclusive, perhaps do an MRI, because you do find cases where the mammogram actually doesn't also help with finding the mass itself. But if there's a high or strong suspicion, then further investigation would be warranted. And then moving on to the invasive or infiltrating ductal carcinoma, this is the cancer that metastasizes. And this is the most common cancer affecting women. So this occurs in around 75 to 89% of cases. And usually, like I said, it spreads. Moving on to the next slide, we move on to the infiltrating lobular carcinoma. So this one occurs in women, and as well in women and female and men. Can we move to yeah, thank you. And what it does, it also spreads, but it occurs less commonly compared to the infiltrating ductal carcinoma. Like I said, that the ductal carcinoma actually has an incidence of 75 to 89% of cases that do occur. This one having 15%, so much less. So the medullary carcinoma, this one is quite common in young females, and it's associated with what we call the breast cancer gene 1. So what a breast cancer gene 1 is, it's actually a gene that we all have, and it's responsible for actually regulating the cell differentiation or division. When there is a mutation to this gene, then it can actually assist with halting an uncontrolled cell division, which occurs in cancer cases. So in terms of the mucinous carcinoma, also a cancer that occurs in females and males, but this is less common. So you get in less than 5% of cases. And it's quite common in women that are of the age of more than 50. And then we then have papillary carcinoma, if you can move to the next slide. This is also an uncommon cancer, occurring in around about 1 to 2% of cases, and also occurring in women aged more than 60. The metaplastic breast carcinoma, quite common in African females, and also quite rare, but it does occur in around about 1% of cases. Then we have the phylloides tumor. Phylloides comes from a Greek word, phylloides. Basically, it means leaf-like, and it just says that this cancer has a pattern of spreading in a leaf-like pattern. And it's quite predominant in the premenopausal women between the ages of 40 to 50. And it's quite also rare to have an uncommon, with cases occurring less than 1%. We can move to the next slide, Sabu, thank you. So in terms of risk factors, these are very important, and this is why when you meet your doctor, these are the details that you need to be sharing with your doctor. So age is quite an important factor, and as you've seen with most of the types of breast cancers, it occurs in women which are much older. So the peak or incidence being between the age of 50 to 69. Family history is also quite a big factor. With first-degree family history, causing at least 1.5 to a 3-fold increase in a risk of actually developing breast cancer. And this is associated with certain gene mutations I'll go into detail on. As well, a family history of ovarian cancer. Ovarian cancer also is related to some mutations that may be running in the family that may predispose you to breast cancer. And women that have had ovarian cancer actually are at a risk of developing breast cancer as a result. So in terms of genetic mutations, we speak of the BRCA1, BRCA2 gene mutation. I've already touched on these. And these, we have these genes normally. They are there to regulate cell differentiation. But in some cases, when there's mutations to them, that they're not able to assist. So you do get families that have these genes. And in such cases, you can find that, it runs in the first degree, second degree, or you find that your grandparents, your aunts, have actually had breast cancer in the past. As well, the Ashkenazi Jewish population. So they found that actually they have an increased incidence of having that BRCA1 gene mutation, hence the association. When it comes to previous neoplastic or cancer experiences, so females who've had previous breast cancer, say you've had a breast cancer in your right breast, and it gets treated, you might actually have a risk of developing a breast cancer in the contralateral side, which would be in this case the left breast. So also I mentioned ovarian cancer as well, if there's a previous history of ovarian cancer, as well as endometrial cancer, that does increase the risk of developing breast cancer. Coming to hormonal therapy, interestingly enough, a lot of women use oral contraception, and I would say hormonally based contraception in this case. Some of the cancers that develop actually depend on female hormones like your estrogen and progesterone for them to grow. So most of the hormonal therapy that we have these hormones and act as sort of a stimulant to the breast cancer cells for them to grow. Hormonal replacement therapy, especially in postmenopausal women as well. So these are the hormones that usually go down during the postmenopausal period, and they receive treatment, especially to treat some of the symptoms that come with menopause. In terms of the menstrual and obstetric history, this also speaks to the exposure to levels of estrogen and progesterone. So the earlier one starts their periods, and they say at age less than 13, that increases your risk. A patient that has actually never had a child because you haven't had that 9-month period without having, not having your periods. And also remember, during pregnancy, the hormone regulation isn't the same as when you're not pregnant. So also women who've had kids at the age beyond 30 as well, that increases your exposure to these hormones that our bodies are naturally producing, as well as women who reach menopause at the age more than 50. Lifestyle also quite important. We know that tobacco smoking is quite a big factor when it comes to a lot of cancers, as well as excessive alcohol intake and previous history of actually receiving radiation to the chest also increases the risk of developing cancer. So can we move to the next slide?
I think it was 80.
Sorry about that. I didn't get that. Okay. So in terms of self-examination and diagnosis, it's very important for women to practice self-examination. And as I've alluded to the symptoms, you look at yourself in the mirror and you look for those signs that might suggest that there's changes occurring to your breast. And then you move on to touching your breast. There is a video that we're going to play briefly that just shows how to do breast examination.
Breast or nipple changes, swollen glands. It might not be a lump. It might be puckering, dimpling, breast or nipple changes, swollen glands, or yes, it might be a lump. Breast cancer is the most common cancer among South African women. So it's important to examine your breasts on the same day every month, 7 to 10 days after your period. If you no longer have your period, choose a day that's easy to remember. To do a proper breast self-examination, follow these 3 easy steps. In front of a mirror, check for any visible breast changes in 4 different positions. First, with your arms at your sides, then overhead, then firmly pressing your hands on your hips, and lastly, bending forward. Lie down on your back with a pillow under your right shoulder and your right hand under your head. Starting below the collarbone, make small circles by pressing down, moving clockwise towards the nipple. Remember to check under the armpit. In the shower, check your breast with the soapy left hand and fingers, using the same technique as lying down. Always repeat these 3 steps on both sides. Tell your doctor if breast cancer runs in the family. After the age of 40, make sure you have a mammogram every year. Cancer care centers offer clinical exams by professional nurses. Early detection can save your life.
Thank you, Sibu. Going back to the slides, I think it's very important to also say that, you know, sometimes it's good to do self breast examination, but
checking your breasts regularly helps you know what's normal for you. Choose a time and place to check.
Thank you, Sibu. All right. I was saying that it's so important that in as much as you can do your breast examinations at home, it's not really the same as doing an exam, you know, that is done by a qualified practitioner, even if it's a nurse, because sometimes it is easy to miss the abnormalities at least once a year to make that check, just like we do, you know, for pap smears. All right. So when we go to diagnostics, very important, you go see your medical practitioner, your doctor. And what they do is that they will take history. So very important, we've noted the risk factors associated with breast cancer, and they identify and sort of risk stratify you. And then they go into the physical examination. All right. And if they do find a lump, what happens next is that they would actually request further investigation or refer you to an appropriate practitioner. A mammogram is an X-ray that we use to actually see if there are lumps in the breast. And actually, women who from the age of 40 actually qualify to do an annual mammogram, even if you are asymptomatic, you're not feeling any lumps, there's no skin changes, because like I said, there are some cancers where you don't have a palpable mass. As well as in some cases, an MRI can be used to investigate you further, especially in cases where you've done an ultrasound, you've done a mammogram, the doctors are still suspecting that there's a lesion there. And MRI is actually very good with soft tissue. It's a good investigation when it comes to that. And as I've mentioned, an ultrasound as well can be used, especially during when they are taking a biopsy, to localize the lesion and take that small piece of that cancer or lesion that's found to the lab, so they can actually determine if it is cancer or not. So biopsies are actually very important, and they help with giving us a definitive diagnosis of whether we are dealing with cancer or not. So there are genetic testing available, but these are very expensive tests, and they should be done in warranted cases. So if you've had a long-standing history of breast cancer in the family, and you're suspecting that even if you don't have a breast mass, you might be at risk, so this can be warranted. And in some cases, people do take these tests, you know, once they're positive and they say you do have BRCA1 or BRCA2 gene mutation, to actually have what we call a prophylactic mastectomy, where they remove the breast before cancer occurs. Thank you, Sibu. Can we move to the next slide? All right. So in terms of treatment and prevention, there are different treatment modalities. So the treatment modalities can go from surgical, doing targeted therapy, introducing radiation or chemotherapy, and also as well hormonal therapy. So in terms of surgical intervention, so if you have a localized sort of tumor or lump, and it hasn't spread, a doctor can actually do a lumpectomy. But I think I must also put this into perspective that when it's reached the stage and they've confirmed breast cancer, you need to actually be seen by a specialist. So a specialist plastic surgeon or a general surgeon, it's a sort of a multidisciplinary team, as well as an oncologist, radiology team that actually work together in treating a patient with confirmed breast cancer. But like I said, so a surgeon would decide, localized lesion, I'll do a lumpectomy. But if it's not localized, they could do actually a mastectomy where they remove the breast tissue. And sometimes they do a modified radical mastectomy, which involves the removing of the breast tissue as well as the lymph nodes that are associated, because we did say that the breast cancer actually can spread through the lymphatics. So you might find that the axillary lymph nodes or armpit lymph nodes are also having cancer. So those get removed. In terms of targeted therapy, this looks at the specific receptors that the breast cancer has, and they introduce drugs that act against those specific proteins that are associated with those receptors to prevent further differentiation, division of the breast cancer cells. So radiation as well can be introduced to stop and try to kill the breast cancer cells. Chemotherapy as well, we know radiation and chemotherapy go hand in hand sometimes, and this helps them to actually eradicate the cancer that is present. And outside of just doing a removal of the breast tissue, you could find that in some cases this has actually spread and you require further treatment in that regard. And this usually is what the oncology team or nuclear medicine team actually does. So hormonal therapy, in regard to this speaks to, like I said, there are cancers actually that depend on hormones like estrogen and progesterone. So in this regard, what a doctor would do is that they would introduce treatment like your tamoxifen to actually prevent, the impact of your own endogenous or your own body's estrogen from further causing, more replication or uncontrollable division of these breast cancer cells. All right. And then I think the next slide would be on how do we actually prevent or reduce the risk of breast cancer. Unfortunately, in some cases, in as much as you can live a healthy lifestyle, nature happens, Regardless, you might be very active physically, you might be having a very healthy diet, you may not be smoking, but sometimes it does occur, like we said. There are other risk factors that we need to actually have in mind that may predispose you to cancer. But in some cases, you may find that somebody doesn't even have family history or any genetic mutations associated. But in this case, how do you reduce the risk? So a good nutritional diet that is balanced with vegetables, fruits, whole grain, would be a start. Exercising. Some studies actually, which are low level evidence though, suggest that actually exercising assists with reducing the rate of replication or division of cancer cells, and it can actually assist in the precancerous stage of before developing cancer. And of course, avoiding tobacco, excessive smoking and alcohol consumption as well, and breastfeeding. So what they say about breastfeeding is that usually with breastfeeding, there's lower levels of estrogen in the body. So then it also reduces the risk of developing breast cancer. Ladies and gentlemen, I would like to take your questions. I've seen that there were questions sent onto the chat. Oh, sorry about that. Oh gosh, my excuse. I've just been seeing those questions. I'm eager to answer. Support is quite important. That's one thing that actually shouldn't miss. And we have organizations that go into providing information in terms of what breast cancer is, what is available in terms of treatment, what to look for, and also giving you avenues of where to find assistance. Some of these NGOs actually also provide free breast examinations, but in cases whereby, you need assistance in terms of emotional support, finding information on how to get assistance further. And so we do have the cancer organization, which actually is quite well known in terms of number of cancer conditions, but also is quite helpful in terms of providing assistance with breast cancer cases. The Breast Health Foundation as well, although based in Johannesburg, if you go on the site, they're quite informative, in terms of education, and also they have a support line in terms of, if you're inquiring more information and support. We have the Reach for Recovery, which is an organization that is mostly for support emotionally, for supporting the family and the patients with breast cancer, and as well provide information on breast cancer. Okay. All right, so I'm eager to see the questions that were posted in the chat. I'm not too sure, Fatin, how many questions can we take to also
Doc?
allow?
Doc, what we'll do is we'll address 2 or 3 questions now, and then we'll hold all the rest up for the end after everybody's spoken, if you don't mind. But
Yes.
so the first question that's come up is from Vili Manana. He wants to know if this is all applicable to men as well.
So yes, men, like I said earlier, there is an incidence of between 1 to 3%, which is quite rare, but you do have men that do develop breast cancer. So it is also applicable to men, but predominantly, this occurs a lot more in females, but does occur in males.
Okay, then we've got Tama is asking, what happens if the breast cancer test shows a wrong result, either saying there's cancer when there isn't or missing cancer when it's there? How often does this happen?
I'm not a breast specialist, so I usually refer to, plastic surgeons or general surgeons who are specialists in this regard. But a lot of the times it's uncommon unless the specimen. So remember, when a doctor sees you, it's not just, they don't just take a specimen. They look at you holistically with your symptoms, your family history. And if, say, you go and have an ultrasound guided biopsy, so basically they are seeing where they're taking that piece of tissue. If there is actually a test result from the laboratory that says, no, this is normal tissue, if a doctor's suspicion is still there, they would probably send you back for further testing again. But it's quite rare because, like I said, it's not just the clinical diagnosis. They actually do confirmatory tests that actually see if indeed these cells are malignant or not. But a doctor in that regard would send you back if they are having a high suspicion of cancer. Because you do have, people that develop lumps and you find that it's a benign. So benign meaning it's non-cancerous, like your fibroadenomas. Usually those can actually regress on their own, or if that doesn't happen, they actually can be taken out. But those are non-cancerous growths.
Doc, our last question for this round is, if breasts are different in size, for example, can that be an indicator of breast cancer? And how much of a difference is natural, or how much should be a concern?
Okay, I'm not able to answer that question. We do naturally have breasts that differ in size, but you do get people that have, bigger breasts that are just sort of disproportionate in a way. And in those cases, it doesn't actually mean that you have cancer. But I would say that, self-examination, seeking medical attention to just further assess your breast tissue can assist. But in some cases, women that do have an issue with disproportionate breasts and it's causing issues with finding the right bra sizes, you could actually look into perhaps having a breast reduction. I hope that answers your question.
Thank you, Doc. That's wonderful for now. Let's move on to our next speaker. Doc, are you staying in the room toward the end for questions at the end, perhaps?
Yes, I am.
Wonderful. Thank you.
Okay, perfect. Thank you so much, Doctor. We've all learned something there. I've definitely learned something, and thank you for that insightful information. Now, I think it is safe to say we all know someone that has experienced breast cancer, and now we have a survivor amongst us, which is just quite an amazing experience for all of us. Luckily, she is close to us in this family at Workforce Healthcare. She is Monica Corbett's mother, and her name is Alida Bezuidenhout. Please take on the stage.
Alida, are you there?
We would love to hear the story and how you have gone through this miraculous experience.
Give us just a moment, Sibo. I don't see
Absolutely.
Alida if we can,
Mhm.
to not hold up proceedings, perhaps Leslie Clark would go instead, and I'll call a leader on the phone.
Okay, sure. Mr. Leslie himself, Clark, who has been a companion to his wife during a struggle of times with breast cancer. We would love to hear how your experience was as being a companion next to somebody who has suffered. Okay.
Hi guys.
Yeah. Oh, yeah.
Yeah, I'm here. I just don't know where my video. I can't show you my video, but it's probably a good thing for you guys.
No, sorry, guys, that's my fault. Let me enable your video, Leslie. Sorry about that. Give me a moment, but carry on.
Okay, no problem. Hi guys. Okay, yeah, sure.
I have enabled your camera.
Not yet, Sibo. I'm still trying to figure it out. Forgive me. Please carry on.
Okay.
Perfect.
Alrighty. Shall I start talking in the meantime? Oh wait, I think I can do it now. Hang on, I think I can do it now.
Yay.
You just there you go.
Awesome.
Hi guys. Okay. So I've just got to line up the cameras and everything. All right. Okay. Yeah, sure. Yeah. How do I start this? So yeah, Sinead and I, we met and we were sort of partners in everything we did. You know, in partners in crime, we sort of experienced the world together and everything like that. So when the cancer diagnosis came, we sort of realized, you know, sure, this is quite a moment. It's sort of we didn't know what to do. We didn't know at all, you know, what was coming up or anything like that. It was a little bit of a bit of a moment for us, tricky and all of that type of stuff. She had always supported me with my visual and hearing issues. You know, she's always been my shield mate and everything. And now suddenly, boom, it's my turn to support her. Just yeah, yeah. So she's pretty much my shield mate, and so we got the diagnosis. There's a whole story behind that. It was a bit of a mess or whatever. But we thought we'd caught it early enough. But then we were told that unfortunately the type of cancer was difficult to treat in that they have markers on it, and then based on those markers, they can design a treatment plan for it. However, Sinead was what they call triple negative. So they said that the treatment is unpredictable. So they tried to cover, they were very, very good. The oncologist was very, very good for us and everything like that. They walked us through everything. The one experience that we did have with the doctor was she trying to sugarcoat everything and, you know, trying to be nice and be kind, and Sinead turned around and said, hang on, stop. You need to give it to me straight. I'm not gonna, you know, don't sugarcoat it. I need to hear the details, then we can plan. And the doctor sort of took a step back and said, oh, okay, this is unusual. And then started to giving us proper details of what exactly was going to happen. Yeah, we didn't doubt that the doctor was going to do a good plan or anything. We just needed to know so we could be comfortable with the treatment. She was very, very good and very helpful in that regard. Yeah, so, but now, so we got this treatment, and then she gave us a couple of numbers, and now we sort of, you know, had to go and look up all this research, all of this stuff. Everything was, it just became a lot of reading, reading. And the problem is, when you go on the internet, I'm sure you guys have already experienced this. When you go on the internet, there's a lot of woo, you know. So yeah, if you eat 4 pieces of garlic and a piece of ginger, your breast cancer will be cured, or smoke marijuana, or, you know, that type of thing. There's a lot of woo that you could have sort of try and get your way through, which was very tricky, very difficult for us. fortunately, a million years ago, when I was a student, I did do biochemistry, so I was able to sort of say, oh, no, that doesn't feel right. So we were fortunate that I had a privileged education, in that we could sort of see, oh, this is not right, or this is right, or whatever. But also the doctors were very, very helpful. So we sort of, what is this? This treatment? I'm sure you've heard of in the breast cancer world. There's a treatment called Cansema. Do not use it. It's a hoax and everything. But the marketing around it is incredible. It's you look at it and you think, shit, this is a feasible plan. This will cure us. And meanwhile, it's not at all. It's just a big marketing gimmick. And we experienced a lot of that, but fortunately the medical guys were helpful in that regard and everything like that. So that's the whole medical treatment. We got the schedules, the plans, everything like that. But now the thing is, you need to, within this whole chemo thing, it's a very tedious roundabout. It's like on a merry-go-round. The whole you go for your blood work. Once you got your blood work, if the paperwork is fine, then you get the chemo. Then you're going to have basically you off work for 2 days or off work for a day, depending on your treatment, so that you can sleep. Then you got your 2 weeks of trying to build it up again. You have to watch what you eat. Everything is easy to digest food. You can't just eat anything. You've got to eat easy to digest food. So there are going to be days where Jeanette didn't want to eat, so I kind of had to make ensure and sort of that type of thing. Initially, Jeanette was very, very strong physically. She was a very strong woman, but initially she was strong enough to plant our pecan nut orchard. And stuff like that. So she sort of said, no, I need a project to get going. I need a project to keep me interested, keep me going, and so she planted a whole bunch of pecan nut trees. And we had a nice orchard, and the orchard is still there. It's beautiful, and I think of it every day when I see it. So it's one of those special things. What else? So within the treatment of everything, we had to build these routines, and sort of, because there are going to be days where you just don't feel like doing anything, but you need to have a checklist every day. Have I done this? You need a regimen to follow. And the doctors are very good at giving us regimens, but we're not very good at following those regimens. So as a supporter, I found that I had to schedule the sort of have you taken this tablet? And I had a million phone alarms on my phone reminding me, don't this and do this. And Jeanette and I, we worked out a way, and it was good. The interesting thing was just going through COVID with we were quite lucky in that we have a beautiful place where we are. We're out on a small holding in the middle of nowhere. So we didn't really feel what the city people felt, and we're already isolated. We're already used to that, and I think the little community we have here also sort of wrapped around us. So they were part of a routine. Vicky collected our stepdaughter, took her to school and back. Initially before the very hard lockdown and stuff like that, and it was just sort of a nice community sort of thing that helped us. So essentially, you need to build up a routine. You need to build up. This is the next step. You need to build up your support group, your people. Initially, a lot of people offered us help. It was fantastic, but as time goes on, and after it's like I said, it's a tedious roundabout thing, and it doesn't last just a week or whatever. It's months. It's lots of multiple months, and so the problem is that people, they promise something, and then like in a month's time, we can't do this anymore. And without judgment, I can't judge them. They sort of backed out. So I don't know how to give people advice on building up your support team. It's one of those sort of organic things. Your different friends have different strengths and whatever. There were a lot of people that were there for Sanette in listening and stuff, which is fantastic because I'm a quiet person and Sanette needed a noisy person. I'm not listening to me talking now. You say, no, Les is not at all. But normally I'm quite quiet and reserved and everything. So shame, poor Sanette had to put up with this this quiet guy, and then she had her friends, a support group, and we had some excellent people who sort of we found them as we went on. They sort of we sort of filtered down the list of the people we could rely on. So, me being visually impaired, I couldn't go shopping. I couldn't just drive and go shopping myself. I had to get a lift, and those people sort of helped us a lot. And then okay, so and then the other part of this journey or whatever is you have these difficult conversations. The first conversation, shit, we now have cancer, we have to deal with it. So that's the conversation is quite an easy one because now it's right at the start. You can start listing plans. You can say, all right, we need to talk to the doctor. This is the chemo plan. You build it up over a week. What your plan is, whatever. But then, well, as happened to Sanette, suddenly it spread to the lungs, and that was that was one of the hardest things that we had to deal with, where we suddenly going from this very hopeful breast cancer can be treated sort of mindset to lung cancer, or in her case, it was a form that is terminal. It was difficult for us to go through that conversation. We had to sort of figure out what we needed to do and everything. But fortunately for us, we were able to sort of bury ourselves in the detail. We had to organize an oxygen machine. We had to organize the new chemo treatment. There was a lot of distractions or whatever that sort of happened. And, I was able to bury myself in this and sort of, and I hate to admit it, but it was essentially, we took the human out of the suffering. We sort of broke it down into a problem, and that was wrong. What we found out is that the oxygen machine was a bit of a problem, and Sanette could still sort of drive initially. So we decided we were going to go on a date, and we sort of organized with the restaurant a extension cable and everything. We drove there. It was a very short drive, a 5-minute drive, plugged the oxygen machine in. Sanette was comfortable and everything. And I remember just sitting back and looking at her and saying, thinking to myself, she's so happy, so this is a good moment for her. And then I looked, she had that sort of oxygen hose under her nose, and something in me sort of just said, shit, life is never going to be normal again. This is it. This is our new, and I also realized then that she was going to die, and it's like, it was difficult, but so at that moment I sort of realized, oh shit, you know what? This is no longer about the treatment. That's still important. So I moved at that moment. I moved from beyond being a treatment to this is a human being. This is somebody who needs me, needs to make memories, needs to all of that thing. So from there on, and we had that conversation very briefly after that, where I said, look, we need to start generating memories. Sanette had 2 children who we needed to generate memories for them. Fortunately, they were upper teens, so they had a better understanding of what was going on. It was just we had to generate those memories and stuff. Please let me know if I'm over over my time or not, or but yeah, do you have the difficult conversations, especially if you're terminal? The hardest conversation we had was, where do you want to pass away? And Sanette was adamant, I want to pass away at home. And it was a strange conversation to have. You're sitting there, you're having this conversation, you're talking to this person. It's it was surreal. But she was adamant she wanted to pass away at home, and I was immensely glad to have had that conversation, because we were presented with that situation where she had on the day she passed, she had an aneurysm. It went from the lung into the brain, and the brain cancer ultimately is what killed her. But the aneurysm, she was still very aware, but she was unable to talk, and basically all her stuff started fading. And the ambulance people arrived and they said, right, we need to take her. And she started getting a bit panicky and said, no, and I think she knew then that she was leaving us. And I said to the ambulance, okay, she would like to stay here. She would like to pass away here. And then I had to fill in a form. But if we hadn't had that conversation earlier, life would have been, I wouldn't be able to make a decision. It's a very, very hard decision to make. But because we'd had the conversation, it was easier. So basically, we decided that she would stay at home. We had a nurse with us who helped us through the whole process, and it was, difficult. What else?
Okay, Mr. Clark.
Yeah, Paul.
Thank you so much.
Okay.
Very insightful. For me, it was the date night. I loved that part. The fact that you guys were still able to go on a date and create those memories. The fact that you still wanted to create those memories, especially for the kids. Very touching. I loved it. It was the best. And to have such a support like you is amazing. So thank you. I just want to say that before I hand over to the questions, because there are questions that people want to ask you.
Oh dear. Okay.
So I just want to get through to those questions. Max, I don't know if you can help me with the questions quickly.
I think perhaps let's ask people to, unmute themselves and ask Leslie directly. What do you guys think? Is that possible?
I'm good with it.
If not,
absolutely. If anyone can put their hands up, but I do know that we're getting quite a few messages on the side. Just to quickly, okay, Janelle was the first one. If Dr. Lesedi will be able to also take questions after this as well, just the last batch of questions regarding people's concerns as well. Okay. Okay, Janelle.
Good morning, everyone. Good morning, Clark. Mr. Clark, what I'm going to say is not a question. I just wanted to say thank you for being there for your wife throughout all these things, because it only takes somebody who's been going through that to understand what your support meant to her.
It's a partnership. So, So, thank you.
Well, in just as a segue, Mr. Clark, I want to tell everybody that I literally found you on Facebook, but I found you there because of your wife while she was posting and sharing her story. And so I'm so grateful that you've joined us, because we don't often hear from the people who have supported those who have either survived or passed on. And it's an important story to tell. So we're very, very grateful that you've come and shared your story. And I know from what you've told me that you and Sanette have had visions of how you can support others beyond her passing. So her memory lives on. And I'm So grateful you've come and shared part of that with us. Sibu,
Yeah, we're trying to start the supporters sort of thing. You know, how do they cope and stuff? So yeah, so thank you very much. Yeah.
so wonderful. Let's take the show of hands, Sibu.
There's a hand, I think it's from Ms. Morimi. Mr. Morimi.
Okay.
Yes.
Yeah, no, thanks, colleagues. I share the same feelings, but my observation is that Mr. Clark is still emotional. Every time she talks about it, she enjoys talking, but he is looking not totally healed. Any forms of intervention and more support for him for the support, right? Thank you.
Okay. So you're asking if he's counselling or not?
The gentleman is commenting on the fact that perhaps, Mr. Clark, given how heartfelt you've shared, that perhaps you need additional support. Is that something that you feel is ongoing for you? And then you know that you can obviously push our buttons if you need that support.
Yeah, no, absolutely. Yeah, I have received counselling. It has helped a lot. I do still need some, but not as much as say a year ago. Or yeah, but yeah, it is absolutely necessary, and I absolutely encourage it.
Thank you. We've got Tinky van Zyl.
Good day, Mr. Clark. I just want to say thank you, like all the others, for sharing your heartfelt story. You know, once you start walking the road with a person with cancer, whether it's your mother or your wife, your husband, people close to you, I've witnessed so many people in my life dying of cancer, friends and other people, colleagues, and so on. I think to share the detail of what you shared and the realness is extremely important. You know, I was looking at you and listening to you, and I think this is not a YouTube video. This is us listening to a real person who went through a real situation where the news that started good ended not so good. Yet you are alive and you're sharing the alive part and your life carrying on with us. And that's very real and it's very special. And I really want to thank you for your courage and your kindness about it. Thank you that we had the privilege to listen to you, and may God be with you. Thank you.
Thank you. Yeah, Jeanette always said that cancer is not pink. You know, that was her catchphrase. You know, cancer is not pink. You've got to. It's a real thing. You know, there's a Cancer Awareness Month and all of that. So it's all pink and fluffy, and it's great. You know, it's lovely. But she says, you know, cancer is not pink. So yeah, that's exactly true. Yeah.
That's a really good joke. I like that one.
Yeah,
okay.
she was full of jokes.
Yeah. Perfect. So I just want to ask if Dr. Lesedi can come onto camera as well, just to take on the other questions that anybody else had. I see on the side here that Danelle had a couple of questions to ask her. If Dr. Lesedi is still here.
Oh gosh, I think we may have lost Dr. Lesedi, Sibu. In fact, okay. Ladies and gentlemen, I must say, other than Leslie, our breast cancer survivor, Alida Bezaidenot, we've lost her too due to technical issues. So I think for now, that's a wrap for today. This beautiful, vulnerable, brave space is a wrap. Please, we will tend to all of your questions after the webinar, and I'm going to put up the slide again so that you have, in fact, it doesn't have our contact details, but I'll put it in the chat.
Take your shoes off and jump on this.
And then we'll somebody needs to take off their shoes. There we go. There we go. There are the contact details. That is our national number, cell phone. So please send us a WhatsApp if you need our assistance. I'm quickly going to mute Mersha while she's talking. So please send us WhatsApps on those numbers, and we will provide support for everybody present here today, because as I've said, it's a vulnerable space, but it's also a really brave space. So if you have any questions, we'll try and tend to it as best we can now post-webinar. But even into next week, if you find that things have come up for you during the course of the weekend and you'd like to, debrief it, clear it, discuss it, by all means, we will be there for that support. And then we can always take things further as and when you see fit. The email address is misspelled. I think it is. Thank you, Tatum, for that. It's inquiries, the plural version, at workforcehealthcare.co.za. Thank you for catching that, Tatum. Do I have any wrap-up questions or any comments that anybody wants to make before Sibu gives us all the boot, sending us off on a wonderful weekend?
I'd like to comment. If anybody wants to chat, just reach out. I'm not too sure if you can reach out through Sibu. I think she's got my number, and so does Latin.
Thank you, Leslie.
It's cool.
Thank you.
No problem.
It looks like your support group and Sanet's vision is coming. It's going to grow roots very soon.
I hope so. Yeah. Well, it's going. Yeah. I've got a few of us. We're talking. We got it going. Yeah.
Wonderful. Wonderful. Please lean on us if you need any additional support. We will in any way that we can.
Thank you. Perfect.
You're
Thank
welcome.
you. Okay. So just my last words is to say, Dineo, we have a question.
No, it's not a question. I just wanted to say thank you, everybody. And can you please kindly give us Mr. Clark's information so that we can also get hold of him, because today he touched me more than he understands.
Absolutely. Okay.
Leslie, if you don't mind, I'm going to just post your cell phone number that's on the screen as a start for anybody to get hold of you. Is that okay?
That's perfect. That's fine.
Wonderful.
Okay. And so that brings us to the end of this very good webinar, actually. Very touched, very moved, very informed. It was amazing. So I just want to say thank you so much to everybody who joined us today, taking the time out of your day, especially on a Friday, getting ready for the weekend, but it's also the best way to start the weekend. And having support people like yourself, Mr. Clark, is just the absolute best. And knowing that we have such people in this country is just great. And moving forward, we want the Boks to win.
Even if it's only by 1 point, it's okay.
I was very tempted to wear my Boks shirt today, but but yeah, thank you so much and have a lovely weekend, everybody. Thank you.
Thank you, everybody.
All right.
Okay, bye. Thank you.
Cheers. Bye.
Bye-bye.
Thank you, everybody. Bye. Have a wonderful weekend.
Thank you, colleagues. And
Thank you,
Dike Lady, for inviting us.
You're so welcome. Let us know if you want follow-ups and what topics you'd like us to discuss.
A conversation with Mr. Clark.
Wonderful, Mr. Clark. You're going to be up again.